Hi, good afternoon to one and all attending this live video session. I'm Dr. Karthik Anand, consultant orthopedic surgeon specialized into arthroscopy and sports injuries from MGM Healthcare Chennai. So today I'm going to discuss about the topic called how to evaluate meniscus injuries. So in this talk, I'm going to talk about what is meniscus and what are the types of meniscal tears and what are its importance which we see in the MRA and what is the treatment protocols. So before I start, I would like to take this opportunity and thank the Alleviate Pain Clinic directors, Dr. Faraz and Dr. Swagtesh, for giving me this opportunity and also to be a part of their team and family. So my interest and training into arthroscopy was for the last 4 years, and I've been trained under consultants from UK, US, and from Mumbai. So anatomy. So anatomy of the knee joint. So knee joint is a large complex hinge joint which has the tibiofemoral articulation and the patellofemoral articulation. So the knee joint has a total of 6 ligaments, in which 2 ligaments are the extra-articular ligaments, which is the lateral collateral ligament and the medial collateral ligament. So these 2 ligaments are outside the knee joint. There are 4 ligaments which are inside the knee joint, which are called as the intra-articular ligaments. These are the ACL, which is the anterior cruciate ligament, PCL, posterior cruciate, which is in the posterior part of the knee, and there are 2 structures which are called as the meniscus. So these meniscus is a 2 structure which is a C shape, and these are between the femur and tibia. So in this here, this is a knee joint where you can see this is a meniscus which are 2 C-shaped. One is on the either medial side and one on the lateral side, which are present between the femur and tibia bone. So the anatomy of the meniscus. So as I said, meniscus there are 2, which is the inner part. The inner meniscus is called as the medial meniscus, and the outer one is the lateral meniscus. So first the medial meniscus. So the medial meniscus is a semi-lunar in shape, and it is thinner in the anterior part, and it is broader in the posterior. And this medial meniscus is completely attached circumferentially into the capsule, and hence it is a very fixed structure. When compared to a lateral meniscus, the lateral is a completely circular in shape, and it is little mobile, and the tear in the lateral meniscus is less common compared to the medial meniscus, because medial meniscus is more fixed and attached circumferentially to the capsule. So the meniscus, what are the components? So meniscus is made up of 60 to 75% of water, 22% of collagen, and 0.8% of glycosaminoglycans, and 0.12% of DNA structure. It's mainly of a type 1 collagen. So the microarchitecture. So what is the structure within the meniscus? So it has 2 fibers. The inner 2/3, which is the radial fibers. These fibers help to transmit the compressive axial load. So from the femur, so when we run or jump, there will be a compressive load on the knee joint from the femur. So this helps to resist the load. The outer 1/3, which are the circumferential fibers, they help to resist the tensile forces. When you have a twisting or anything, they help to counter the tensile forces. So the functions. So there are 5 main functions for the meniscus. So the first main function is the shock absorption, proprioception of the joint, aids in joint stability, and for lubrication of the joint, and for the nutrition. The blood supply to the meniscus is only by the medial geniculate arteries. So in this function of the meniscus, shock absorption. So why should we know about shock absorption? So for example, like in a car, we have the suspension or the shock absorber. So what happens when a car suspension or the shock absorber gets damaged? That leads to a injury to our tires. There will be an early worn out of the tires. Same way in a knee joint, when the meniscus, which is a shock absorber of the knee joint, tears or it wounds out, there will be a counter damage to the cartilage, which leads to the early osteoarthritis. So we need to know about the vascularity of the meniscus. So the meniscus, it's almost circumferentially fixed to the capsule. So the blood supply arises from the capsule. So there are three zones for the meniscus, which is called as a red zone, which is the most vascular part. And the next zone is the red-white zone, which is a zone 2. And zone 3 is the white-white zone, which is the least vascularized. So why should we know about these zones? So depending upon the zone, where the tear occurs, we can come to a conclusion that this tear will heal or it won't heal. So when a tear occurs in the red zone, there is a high chance for it to heal completely. And when the tear occurs in the red-white zone, there is a less chance it can heal or it may not heal also. And the tears in the white-white zone, there's a very unlikely chance for it to heal. So the tears in the white-white zone may require a meniscectomy, which is a partial removal of the meniscal tissues. So the meniscus injuries can occur due to any sports and due to any trauma, even a small slip and fall from a two-wheeler, or due to any fall from at your home also, you can have this meniscus injuries. So what is the first symptom if you have a meniscal injury? There will be a pain on either on the medial side or on the lateral side. And there will be a limitation of your knee range of movements. And you can have a symptom called as a locking episodes. So what is locking episode is, so when you try to flex your knee and bend, extend your knee, you'll have something like a feel of catching, which is within your knee. So this is called as a locking episodes. So the locking episode can be due to one of type of a tear, which is called as a bucket handle tear, which I'll be talking about it in the next slides. And the next symptom is the instability. So what is instability? Instability means you may feel that when you're walking, your knee is slipping away or it's giving away. So that is called as the instability feel, which is more commonly seen following a ACL tear. And there'll be a delayed swelling in your knee joint. So around like 65% of the meniscal tears are generally associated with the ACL injuries. So as I said, locking episodes. So locking episodes of the knee can be due to a mechanical block. It can be two reasons, either bucket handle tear of the meniscus, or it can be due to a loose bodies within the knee joint, which is most commonly seen in the degenerative osteoarthritis. So if you have this symptom of locking of your knee, then you may require a proper radiographic evaluation and an early intervention. So coming to examination. So with your symptoms, if you're suspecting of meniscal tears, so there are three tests which we can rule out if there is a meniscal tear is there or not. So first is the joint line tenderness. So this joint line tenderness is sensitive of 89% and specific of 97%. So how do you do is, you palpate the tibial tuberosity, go up to the patellar tendon, and you'll feel a small depression, which is soft and you go along the medial side and the lateral side. So any pain on the either side, which is a classical called as a joint line tenderness, which is highly specific, 97% for the meniscal tears. So next is the test which is called as a McMurray's test. So for the medial meniscus, what you do is you flex the knee completely, externally rotate the leg, and then try to slowly extend the knee. So when you're doing this maneuver, the patient will say that he's having classical pain on the medial part of his knee joint. Same way in lateral meniscus, you completely flex the knee, then internally rotate the leg, and then slowly extend the knee joint. Here he'll have a classical pain on the lateral side. So a finding with the medial joint line tenderness positive and with this McMurray's test positive is a classical for a meniscal tear. So this is the grades of meniscus. So these grades of meniscus are to be known if you want to treat the meniscal injuries. So there are 4 grades. Grade 1, as you can see here, which is the complete normal. Grade 2 is a small hypointensity within the meniscus. So the meniscus in this sagittal cuts looks like a small triangular in shape. So when you see a small hypointensity, that is a intermeniscal tear. So the type 2 is the small meniscal hypointensity which extending up to the capsular region. Type 3 is the complete separation of the articular surface of the meniscus. So here you can see the complete triangular portion of the meniscus is disrupted. So when you see a type 3 meniscal tear, then there is high chance the patient can have a classical symptoms of meniscal. As I said, the joint line tenderness and the McMurray's test will be positive for the grade 3 meniscus, and these patients may require a surgical intervention. So what are the types of meniscal tear? So there are different types of meniscal tear. So the common tears, what we see in our practice is the longitudinal tear, which is within the meniscus. It can occur in any zones of the meniscus. Next is the radial tear, and as I said, the bucket handle tear, and then it can be a complex tear or a horizontal cleavage tears also. So here you can see different types of tears. This is a radial tear. This is a parrot beak, which is also called as an oblique tear, and this is a bucket handle tear. The mechanism of the bucket handle tear is that the tear happens and the part of the meniscus flips within the knee joint. So when this happens, the articular surface between the femur and tibia gets locked, and this causes a severe pain in the knee joint. So here I want to explain what are the types of tears and how do you diagnose these tears in the MRI and what we see in the arthroscopic of the joint also. So when you get an MRI of this, you see in a sagittal cut and a coronal cuts. So here the triangular portion of the meniscus, where you can see a hypointensity changes which is within the meniscus. So this is called as an horizontal cleavage tear. Here the tear is between the meniscus, whereas the articular portion of the meniscus, superior articular portion and the inferior articular portion are completely normal. So patients with horizontal cleavage tear may not have a classical findings of medial joint line tenderness or a McMurray's positive. If it is associated with a flap tear or a complex tear, then they can have a significant pain. So this is a patient who had a complex tear where you can see a part of a flap has been happened, and then once the portion in the zone 1, which I said is the white zone, there's less likely chances for it to heal. So we take a few bites and trim out of the zone 1. And then once we trim the zone 1, the zone 2, you can see a horizontal cleavage tear. So this horizontal cleavage tear is called as a fish mouth opening. So what does this fish mouth opening means? So whatever joint fluid which is there within our knee joint can sweep in through this horizontal cleavage, and it can form a small meniscal cyst in the posterior part of the meniscus. This can lead to a pain. So it's always when you see a horizontal cleavage tear, it's better to close this with a repair, which is an all inside technique. So here you take a bite on the superior portion of the meniscus and an inferior portion of the meniscus, and you close the fish mouth completely so that the joint fluid doesn't enter out. So the next type of tear is the very common one, which is the longitudinal tear. Here you can see that the triangular portion of the meniscus, the hypointensity line is between the superior articular surface and the inferior articular surface. So it is completely disrupts the two articular surface of the meniscus. So these type of tears will have a classical findings of the joint line tenderness with McMurray's test positive. So it's not that the longitudinal tear has to be a complete tear. So here in this video you can see the superior articular surface is normal, whereas the inferior articular portion has a small longitudinal tear. So there can be a partial longitudinal tear. So next is the complex tears. So in complex tears, here it's a composition of 2 or 3 types of tears, like a longitudinal tear associated with the horizontal cleavage tear can form a complex tears. So in these type of tears, the repair of the meniscus is very unlikely. So only a good portion or a good quality tissue of meniscus can be repaired in this situations. So here you can see this is a lateral meniscus where you can see there is a radial tear associated with a flap tear. So this part of the meniscus you won't be able to repair it. So we trim that portion, and this radial part of the meniscus is also been trimmed. The balance part of the zone 3 of the meniscus is stable and it's left alone. So the next is the bucket handle tear. So the classical finding for the bucket handle tear in a meniscus, when you see an MRI like this in the sagittal view, you can see a sign which is called as a double PCL sign. So the red arrow shows the normal PCL. So this is a normal PCL, and whereas the yellow arrow, the small one, is called as the meniscus. The meniscus is flipped back, and that is showing as a double PCL sign. So when you see this sign in your MRI, it is a classical finding for a bucket handle tear, and these patients can have a locking of the knee, and they won't be able to completely straighten their knee, and they may have a severe pain also. So here you can see the meniscus is being flipped into the joint. So we are trying to unflip the meniscus, and here you can see this is a bucket handle tear. It's been repaired with the all inside device. So once it's repaired, completely stable, and the outside in techniques also have been used. So the complete portion of the meniscus is being stabilized. So the last two types of tears, which are also called as the hidden lesions. So there are two types of tears which is called as a ramp tear or the root tears. So these two are called as a hidden lesions. So why do we say as a hidden lesions is, these are easily missed in the MRI and well as when you do a diagnostic arthroscopy also. So first we'll see about the ramp lesion. So the ramp lesion is a meniscal tear at the meniscocapsular junction. So it occurs in the beyond the zone 3 junction. So it is easily missed during diagnostic, and this leads to a meniscal extrusion, and repair of this meniscus will give an excellent result to the knee joint. So the MRI, when you see a sagittal cut for MRI, here you can see the triangular portion of the meniscus is completely normal. There's no hypo-intensity changes within the meniscus. But when you see next to the meniscus, there is a small signal intensity change between the meniscus and the two black dots, which is the capsule. So this is called as the meniscocapsular separation of the meniscus, which is otherwise called as a ramp lesion. So in this picture also, you can see this yellow line arrow mark showing separation of the capsule and the meniscus. So when you see a arthroscopic video, when we try to pull the meniscus out, you may think this is a completely normal, but you need to put a posterior portal, and once you make a posterior portal, you will be able to see that there is a tear which is beyond the meniscus at the capsular junction. So you trim the part which is frayed, the meniscal part. This is the trimming of the meniscus and the capsule using a shaver. And then once you trim, you assess the meniscus, and then you take a bite. So now the meniscus and the capsule are being repaired to each other. So this gives an excellent stability to the knee joint. These meniscus tears can be easily missed, which can lead to a bucket handle tears in future. So two knots have been placed and the meniscus is completely repaired to the capsule. So the next one was the meniscal root tears. So these are the ones also which are easily missed in the MRI and by diagnostic. These tears are most commonly seen in the 4th or 5th decade of your life, and it can be due to osteoarthritic changes also, due to degenerative osteoarthritis also. And the classical symptom in meniscal root tears is, even with a trivial fall, you can have these tears. So good results are expected with early diagnosis and a good arthroscopic repair. So on MRI, when you take a coronal cuts. In this cut, where you can see a white arrow mark is showing that there will be a hypointensity change where the meniscus root goes and attaches. Here the root tears are most common and only in the posterior root tears are very common. Anterior root tears also can happen, but posterior are more common. And when you see a sagittal cuts, when you see from the topmost cut, you can see the triangular portion of the meniscus. But as the cuts go deeper and deeper, you can see that the black triangular portion of the meniscus is fading out. And in this one cut where you can see there's no meniscus seen. So this sign is called as a ghost sign, which is a classical for the root tears. This is an arthroscopic video where you can see inside the knee joint. So this is a meniscus which is attached to the tibial plateau. So we check the mobility of the meniscus. So this part of the meniscus has to be attached to the bone. We take a tunnel into the tibial plateau. Then 2 bites are taken with the high strength sutures. So 1 bite and the second bite is taken just medial to that first one. Once the 2 bites are taken, the sutures are passed through the tunnel what we have made before, and then it's pulled back and it's been tied in the tibial plateau, the anterior surface of the tibia. So the other one, which is a discoid meniscus. So this was described by Watanabe. It is commonly affects the lateral meniscus. It is a type of a congenital anomaly which is seen in few people. It's more commonly affects in the lateral meniscus. So when you see a MRA of this kind, when you see in a sagittal cut on the lateral side, you can see the meniscus is being completely fused between the anterior horn and the posterior horn. There's no separation between the anterior and the posterior horn. So this is a classical of a discoid meniscus. So the discoid meniscus at the younger age can give a feel of a locking. Sorry. So it can give a locking episodes. They may feel a small clicking sounds in the knee joint. So at a younger age group, when you have these symptoms and when you diagnose this, the best way is to go for an arthroscopic saucerization, which is you remove the excess portion of the meniscus and keep the original part of the meniscus which is required for your knee joint. So as we discussed, these are the different types of meniscal tears which you can see in the meniscus. So what are the treatment modalities? So when you have a meniscus tear, the first thing you need to rule out is whether it's an isolated meniscus tear or whether it's associated with any other ligaments such as an ACL or a PCL. So if you have an isolated meniscal tear, you need to find out whether it's an incomplete tear or a complete tear. If it is an incomplete stable tear, then you can go for a conservative treatment in form of physiotherapy or a regenerative medicine. If it's an unstable tear, then you go for a surgery. Whereas in meniscal tears, which is a complete tear associated with other ligament injuries, you need a early surgery. So coming to the role of regenerative medicine in the meniscal tears. So these meniscal tears, which are of grade 1 and grade 2, can be treated with the regenerative medicine. So in regenerative medicine, we have many different types of stem cell therapies, which is the platelet-rich plasma, which is called as the PRP, the bone marrow aspirate, and then the third one is the prolotherapy. So any of these modalities can be used for the meniscal treatment only if the tear is grade 1 or grade 2. For the grade 3 tears, it is very unlikely to help in healing process because the grade 3 tears can have a lot of functionality issues which can lead to a lot of instability problems also in the knee joint. And incomplete tears or a small tears in zone 3 also can be treated with the regenerative medicine. So what is platelet-rich plasma? The platelet-rich plasma is a stem cell therapy in which your 30 ml of your blood is taken, your own blood, and it's centrifuged for 5 to 10 minutes. And then the rich plasma, which is the platelet-rich content, is injected into your knee joint under ultrasound guided, and maybe 2 to 3 sessions of PRP injections you may require in a meniscal tears of type 1 or type 2. So there are a few articles which have proven that stem cell therapy works in the knee meniscal tears. So these can be used in the knee meniscus tear or even after a post-meniscectomy or a post-meniscal repair conditions also. So the next is the BMAC, which is called as a bone marrow aspirate concentrate. Here what we do is we take the bone marrow content from your bone, which is mainly from the iliac bone. This is also the same way you centrifuge it and take that concentrate and inject into the knee joint. So here the difference between the PRP and the BMAC is the BMAC has a rich in the mesenchymal cells, which helps into the early regeneration of the tissue with growth factors, which helps in the early healing of the meniscus. So once the regenerative medicine is done, so you can use it for the certain conditions where the tear is very small tear or it's a simple tear in the zone 1 and 2, you can use. Whereas in zone 3 tears where you require a surgical intervention, it's by arthroscopic surgery. The different modalities are there. So the types of tear which we are not able to repair, so we go for a partial meniscectomy where we trim the part of meniscus, and the meniscus which are stable, we leave them. Next is the meniscal repair. So the meniscal repair is now a newer generation. There are a lot of techniques have been described. So there are 3 types, which is called as an outside in, and this is done in the anterior horn. When you have an anterior horn or a body tear, you can do an outside in repairs where the needle comes from outside of your knee joint, and there is an inside out, which is done from the inside of your knee joint, which I showed in one of the videos. And posterior horn is the all inside repair, which is done with the device, which is called as the internal device, which helps into repair for the posterior horns of the meniscus. So to conclude, so knowledge of the meniscus anatomy is paramount. It requires a lot of experience to learn about the meniscus and to gain knowledge in how to find out a meniscus in the MRI. So it's no longer a vestigial organ. It has a most important role in our knee joint. So good history with a proper examination helps you to diagnose what type of tear and which zone of tear is there. So identify the pattern of the injury with a grade of tear with an MRI, and always be aware of the hidden lesions, as I said, which is the ramp lesion and the root tears. Regenerative medicine or a repair, whichever you go for depending upon the types of tear, always save the meniscus for the better longevity of the knee. Take home points. So not all the knee pain with medial joint line tenderness is osteoarthritis. So in general, when a lot of people who are above like 45 or 50, when they come with a knee pain, and if they have a arthritic changes, we diagnose them as an osteoarthritis. It's not that way, because with this age group of 4th to 5th decade of life, it's not about the osteoarthritis. There is the other, which I said as a root tears, which is a regenerative root tears, which is very common at this particular age group. So don't put as all joint line tenderness is OA in the 4th or 5th decade of your life. So failure to diagnose and treat the meniscal tears appropriately can lead to an early osteoarthritis. Grade of a meniscus tear and a patient selection plays a vital role in regenerative medicine. Grade 3 tears will always require arthroscopic surgery for a better outcomes. Thank you. So this is my contact number and my email ID. If you guys have any doubts or related to this meniscal injuries or anything, you can contact me or mail me also. Thank you.